CME program conduct ചെയ്യുന്നത്. ഇത് നമ്മുടെ മൂന്നാമത്തെ പ്രോഗ്രാമാണ്. ഇന്നത്തെ ക്രോണിക് കോൺസ്റ്റിപ്പേഷൻ ആണ്.
മ്യൂട്ട് ചെയ്യണം തോന്നുന്നു. ഡിസ്റ്റർബൻസ് മ്യൂട്ട് ചെയ്യണം.
ഒരു മിനിറ്റ് പ്രശാന്ത്. ഇപ്പൊ കുഴപ്പമില്ലല്ലോ. Today this is our third CME program. Our topic is chronic constipation, and today I am privileged to introduce the speaker of today's CME. The speaker is Dr. Prasanth. He is heading the Pediatric Gastro Unit in SAT. I was fortunate to be with Dr. Prasanth, and we did our PG together at SAT. And I think pediatric gastro, നമുക്കിപ്പോൾ ട്രിവാൻഡ്രത്ത് അല്ലെങ്കിൽ പീഡിയാട്രിക് ഗാസ്ട്രോ എന്ന് പറഞ്ഞിട്ട് സ്പെഷ്യലൈസ് ചെയ്തിരിക്കുന്ന ആൾക്കാർ വളരെ കുറവാണ്. എനിക്കൊന്ന് കേരളത്തില് അല്ല ട്രിവാൻഡ്രത്ത് പ്രശാന്ത് ആണ് വൺ ആൻഡ് ഓൺലി പീഡിയാട്രിക് ഗാസ്ട്രോ എന്നാണ് എനിക്ക് തോന്നുന്നത്. അപ്പോ നമ്മുടെ കൊല്ലത്ത് നിന്നുള്ള സാധാരണ എല്ലാ പീഡിയാട്രിക് ഗാസ്ട്രോ കേസസും SIT പ്രശാന്തിന്റെ അടുത്തോട്ടാണ് നമ്മൾ റെഫർ ചെയ്യാറുള്ളത്. അപ്പൊ എന്തെങ്കിലും ഈ ഒരു അവസരം നമുക്ക് പീഡിയാട്രിക് ഗാസ്ട്രോ സാധാരണ നമ്മളിപ്പം ഒരു ഡയറക്റ്റ് ഒരു കോൺവെർസേഷൻ കിട്ടാൻ കുറച്ച് ബുദ്ധിമുട്ടാണ്. അപ്പം I think we will make use of this CME and will clear our doubts from this speaker. And thank you Prashant for receiving your invitation, and over to Dr. Prashant without wasting much time. Over to Dr. Prashant for the talk. റീന മാഡം രണ്ട് വാക്ക് പറയുന്ന.
ഇല്ല മനോജ്, ടൈം കളയണ്ട. എല്ലാവരും ഈഗർലി awaiting for the class.
ശരി ശരി. ഓക്കെ പ്രശാന്ത്.
ഓക്കെ.
Thank you Manoj for the invite and the kind words. മനോജ് സ്ലൈഡ്സ് കാണാമോ?
കാണാം.
ഞാൻ ഫുൾ സ്ക്രീൻ ആക്കട്ടെ. ഉണ്ടാക്കാൻ പറ്റും. മനോജ് സ്ക്രീൻ ഷെയർ റെഡി ആയല്ലോ അല്ലേ?
കാണാം പ്രശാന്ത്.
So very good evening to all of you. As portrayed in the invite in the e-flyer, even though constipation is a very common problem, at times it can be an ordeal both for the parent as well as the caregiver. So this is the format of the discussion I have laid in such a way that there is not much of academic content. Mostly it is a practice oriented. My idea is to highlight some of the common errors in practice and to introduce the scientific concepts in a systematic manner. As all of us are aware, this constipation in children is quite a common problem, and it constitutes roughly 5% of general pediatric office visits, whereas it consumes around 1/3 of referrals to us. The prevalence of this problem is varied, ranging from 0.7% to 29.6%. And one point which I would like to highlight is the fact that just like chronic constipation, chronic abdominal pain is also a fairly common complaint with which referrals are made to pediatric gastroenterologist. Among those children who are referred with the chronic abdominal pain, 1/3 of these children are in fact having functional constipation, which is contributing to the symptomatology. So for any condition, we need to know what are the etiological factors. Having said that, in 90% of the cases, there is no organic basis for constipation in children. In other words, the commonest cause for constipation in children is functional rather than organic. And if you look at the organic etiology, it can be broadly classified into two categories: surgical causes and medical causes. Surgical causes, foremost, we have to rule out local anal pathology like anal fissure, skin tags. Then in the organic category, the one important condition that needs to be kept in mind is Hirschsprung's disease. The classical ones will present quite early in life, and it can be picked up in infancy itself. And other anatomical issues like anteriorly placed anus. Then structural neurological problems like the neural tube defects like spina bifida and meningomyelocele. And if we see the medical part, it can be contributed by a whole group by drugs, most commonly due to the antispasmodic agents and anticholinergic drugs which are prescribed in the management of chronic abdominal pain. And as part of some systemic problem associated with the mental retardation, hypotonia, can be associated with the metabolic and endocrine issues like hypothyroidism, even though the incidence of hypothyroidism is quite not that common with the advent of the newborn screening, etc. The electrolyte disturbances like hypokalemia and hypercalcemia can also be a cause for constipation in children. But the predominant etiology is almost always functional. So let us go through a case with that. We have a 3-year-old girl child who was referred with history of chronic abdominal pain for the last 10 months. This girl has received multiple treatment, including proton pump inhibitors, probiotics, antispasmodics, and has received a short course of multiple laxatives intermittently for a very brief duration. And occasionally she has received rectal suppositories. The child has been dewormed twice. This child has no red flags. I will come into the details of the red flags in the subsequent slides. The basic workup is normal. We'll see whether any workup in itself is really required to make a diagnosis of functional constipation. Diet, the child has been advised, the parents have been advised to cut down milk consumption and to increase green leafy vegetables. But even after trying all these medications and dietary modifications, there has not been any symptomatic relief, and parents are quite frustrated and also worried. On reanalyzing the symptomatology, the pain has been there for the last 10 months. It has been located in the periumbilical region and left lower quadrant. The quality of the pain is pricking type of pain. And on probing, it was ascertained that the girl was having irregular bowels. She used to pass motion once in 4 days with the profuse staining, and the stools were hard, pellety in nature. There has been no history of bleeding per rectum or any urinary symptoms like dysuria, increased frequency, or burning sensation during micturition. On further eliciting the history, this child has been had undergone potty training from 1 year of age. And when the child was asked to defecate, the child used to adopt bizarre posture. What you can see in the picture is that the child is holding to the furniture and is keeping the legs crisscrossed. It may seem that the child is trying to defecate, but the child is actually adopting a withholding posture. This was actually one of our patients. The parents had brought that picture to me. So this is the classical withholding position. Then the child has feed refusal. She vomits the feeds. Is complaining of leaky stools and fecal soiling. This is something which should be kept in mind. The leaky stools may be misconstrued as diarrhea, and management in the line of diarrhea may be given, whereas in fact the actual problem is constipation. Diet, this child is fond of dairy products and chocolates. So further we went on with the physical examination. On examination, the basic examination is quite normal. On perabdominal examination, the child has a lumpy mass in the left lower quadrant, which is apparently a fecal mass. Normal placement of anus. On rectal examination, there is a non-tender anal crack, then there is fecal soiling, and the stool is dry sausage shape. The anal wing and cremasteric reflex are normal, highlighting that there is no neurological issue. So with this, the symptom is there for the last 10 months, so chronic abdominal pain is there. And with the examination and available history, we think that it is a functional constipation. And more important, the child is having fecal impaction. So having gone through the case, what are the common errors in practice? Is there a delay in arriving at a definitive diagnosis? See, in this case itself, the child has received multiple medications with various types of drugs for various durations. Are investigations really essential? How early should toilet training be started? Dietary manipulations alone as a treatment for chronic constipation, will it work or not? Or should it be done alone? Then not resorting to disinfection, because in the case of functional constipation, almost 70% of cases there will be fecal impaction. If we don't resort to disinfection, we are not going to have a good outcome. Then resorting to a short course therapy, that also one after the other, say for 10 days, 14 days, like that, and then after that, seeing no response, probably will switch over to some other medication or some other class. Is that justified? What about using other medications like probiotics and things like that? Is it justified? Before going to the errors, we need to recapitulate some basic concepts as to how this child develops chronic constipation. What is the inciting event, and how that how it results in chronic constipation in the long run. The inciting event is always a painful experience initially. That painful experience may be resulting from a change in routine, change in diet, or exposure to some stressful event, or the child is too busy that he or she postpones defecation, or too early toilet training. That can result in a painful defecation as a first experience. That will cause an urge for the child to withhold defecation subsequently, which withholding will result in prolonged fecal stasis in the rectum. The more the stool is retained in the rectum, that is a conducive environment that will facilitate further absorption of water from the fecal matter. Thereby, the stool is solidified further, and it will increase in size gradually. So this process goes on and will result in fecal impaction. And finally, once the fecal matter is impacted, that will result in overflow fecal incontinence, which may be construed as diarrhea. So much so that in advanced stages, the child will lose the rectal sensation and even urge to defecate. So voluntary withholding is the key problem in the pathogenesis of chronic constipation. There are some fallacies, just like the errors which I mentioned earlier. Fallacy number 1, making diagnosis of functional constipation. Are we missing something? Are we missing the cases? Diagnosing a child with functional constipation, does it require only clinical examination, or do we have to resort to extensive investigations to arrive at a diagnosis? How to identify? In simpler terms, constipation can be defined as a difficulty and delay in passing stools resulting in significant distress. It is termed as acute when the problem is there for less than 14 days, and it is considered as chronic if the symptoms are there for more than 2 weeks. But this is a too simple definition which lacks objectivity. To lend subjectivity, several criteria have been described. One such criteria is ROM4 criteria. Just to remember the name. This is actually a criteria platform for most of the functional GI disorders in children as well as adults. But most of these criteria are actually developed in the West, and we don't have, and there are only few studies validating these criteria in Indian children. So in order to sort out that problem, our society, that is the Indian Society for Pediatric Gastroenterology, Hepatology and Nutrition, they have come up with their guidelines, and it has been published in our prestigious journal, Indian Pediatrics, around 4 years ago. let us see what are the criteria. The symptoms should be there for more than 4 weeks across all ages. Along with that, there should be 2 of the following additional criteria. That is the criteria included are frequency, presence of fecal incontinence or there after the onset acquisition of toileting skills, that is roughly around 4 years of age. Is there any history of excessive stool retention? Is there history of painful or hard bowel movement? Is there presence of large mass in the rectum or on para-abdominal examination, as in the case we have listened to? Then history of large diameter stools that may obstruct the toilet, especially when the child is using European toilet. If the symptom has been there for last 4 weeks, and along with that, if any of the 2 factors are there, it can be deemed as constipation, chronic constipation. But the important point here is that if you rely just on the frequency alone, there is a high chance that we may miss a substantial proportion of children with chronic constipation. So how to lend objectivity to the stool and all? There are some charts which are readily available. This can be used. This is freely available in the net and all. This Bristol stool chart classifies stool into 7 categories based on the consistency. The type 1 is the hard lumps, pellety stools. If the stool is of this nature, then it is almost sure that the child is constipated. And as we go down the list, the consistency actually reduces and it becomes entirely liquid when it becomes a type 7 stools. There are other stool consistency charts also available. Just remember the name, that's all. Apart from the classical symptoms which have been discussed, like pain during defecation, frequency, incontinence, and things like that, we need to keep in mind the other symptoms like fecal incontinence, because many a times the presenting complaint will be like soiling, fecal soiling, and or encoprocess. This term should not be actually used. The correct terminology is fecal incontinence, which will be misconstrued as diarrhea, and the treatment will go on that line. Then blood with defecation, because that prolonged stasis, fecal impaction, the stool getting harder, there is high chance that the child may develop anal fissure, or at times, as shown in the picture, they can develop ulcers in the rectum, which are called as solitary rectal ulcers. Or at times, these children may present with urinary symptom. The child may be coming with urinary symptom, like recurrent UTI, dysuria, burning sensation, or a sense of incomplete voiding, and things like that. If such symptoms are there, you should really ask for bowel symptoms. Then the other form of presentation could be school absenteeism. The children will be reluctant to go to school. So how do we clinically segregate functional versus organic causes of constipation? You can start from the newborn period itself. Normally, we expect the meconium to be passed within 24 to 48 hours. If there is history of delayed passage of meconium, then we should keep in the back of the mind that there could be a possibility of organic. The prototype for organic cause for constipation in children is actually Hirschsprung's disease. Delayed passage is there, then we should be suspicious of Hirschsprung's disease. The age of onset, functional constipation usually starts after infancy, probably 2 to 3 years of age. Whereas if the constipation is of infantile onset, organic etiology should be given due consideration. If fecal incontinence is there, because now we are well versed with the pathophysiology, if fecal incontinence is there, we can be pretty sure that it could be functional constipation. Whereas in organic causes, fecal incontinence is very rare. Anal fissure is quite common in functional, whereas it is rare in organic causes like Hirschsprung's disease. And failure to thrive is quite uncommon with functional constipation, whereas in delayed cases of Hirschsprung's disease, there can be failure to thrive, enterocolitis, and things like that. Abdominal distension is rare in functional constipation, whereas it can be common in organic causes like HD, which will present, in fact, at times with the intestinal features of intestinal obstruction like vomiting, abdominal distension, later on to pick up that the child is having HD. And on rectal examination, if fecal staining is there, we can be sure that we are dealing with functional constipation, whereas an empty rectum on rectal examination may be a pointer towards Hirschsprung's disease. What are the red flags which we should be worried? As already mentioned, constipation starting extremely early in life, that is less than 1 month of age. Always we should rule out organic reasons. Absence of withholding maneuvers. That may be a pointer that we could be dealing with an organic rather than a functional etiology. Delayed passage of meconium beyond 48 hours will be suspicious of conditions like Hirschsprung's disease and rare conditions like cystic fibrosis. Then sometimes children may be having failure to thrive anemia that can be there in HD, and rarely with the celiac disease. Celiac disease is distinctly uncommon in our part of the country. The classical presentation is failure to thrive, anemia, diarrhea, and all. But at times they can present with constipation also. If there is bilious vomiting and abdominal distension along with chronic constipation, then we need to rule out intestinal obstruction also. Empty rectal ampulla on digital rectal examination will be a pointer towards Hirschsprung's disease. The abnormal neurological findings like absent chromatostic reflex, anal wing reflex, etc. may be a pointer to some neurological issue. Then developmental issues like trisomy 21, etc. These children can present with constipation. Recurrent lower respiratory infection along with chronic constipation may be a pointer to conditions like cystic fibrosis. These are the clues for organic conditions. Along with that, any case diagnosed as functional constipation but failed to respond to standard therapy for a fairly sufficient time needs diagnostic reevaluation. That should also be considered as a red flag. Having made the diagnosis, do all cases require a per-rectal examination? They are required if there are red flag symptoms or signs which have been discussed earlier. The onset is less than 6 months of age. If the child is not responding despite a fairly good compliance to therapy for a sufficient period of time, and also to distinguish fecal incontinence, whether it is resulting from constipation or non-retentive incontinence. These are the 4 situations where you can have to do a per-rectal examination. And to make a diagnosis of chronic constipation, do we require abdominal X-ray? So by doing a clinical examination would be sufficient actually. By asking for an X-ray, we are exposing the child to radiation. So per se, there is no role for routine use of abdominal X-ray to diagnose functional constipation. It may be useful if fecal impaction is suspected. As shown in the picture, you can see that the entire rectum and the large bowel is loaded with the fecal matter. So it may be useful in a child if fecal impaction is suspected, but in whom physical examination is unreliable or not possible. Then what about the role of barium enema? So do we really require barium enema for the evaluation of chronic constipation? Is really not required. What you see on the left side is actually a child having chronic constipation for whom barium enema was done. Apparently, we can see barium retained in the rectum. So in cases of chronic constipation, sometimes there can be barium retained in the rectum after 24 hours. This may be misinterpreted as a Hirschsprung's disease, whereas on the right-hand side, what you are seeing is the classical findings of Hirschsprung's disease, where you can see the reversal of the rectosigmoid ratio. You can see a dilated sigmoid and with a transition zone and a narrow rectum. Lab investigations. Do we require lab investigations? Lab investigations for conditions like hypothyroidism in children with constipation is indicated only when there is a suggestion for an underlying organic disease. Otherwise, routinely, such investigations are not warranted. So to conclude, meticulous clinical examination, clinical history, and a complete physical examination, including per-rectal examination, when indicated, are fairly good enough to make diagnosis of functional constipation in more than 95% cases. And fallacy number 2, having made the diagnosis, is it reasonable to adopt a wait and watch policy to treat childhood constipation? So what is the fallout of adopting a wait and watch approach? Children who had constipation for less than 3 months before presentation to the outpatient clinic achieved earlier success than children who had a delayed presentation. And in such children, at 6 months follow-up, studies have proven that 79% of children who presented after less than 3 months were successfully defecating without using laxative, whereas in the delayed presentation group, 32%, in contrast to 32% of children who presented after 3 months. So if we adopt a wait and watch approach, the consequence will be repeated painful defecation and accumulation of feces in the rectum. The child may develop stool withholding behavior, which will be perpetuating a vicious cycle. Fallacy number 3, early toilet training. So what you see in the picture, these are actually relics of potty, which are exhibited in, which are found from prehistoric times in 5th century BC. Even during that time, toilet training was given such importance. Even during those times, you can see this is the newer version. There is not much difference in the design of the potty. So what about toilet training? What is the ideal age? Never before 24 months of age, because the neuronal circuits, the control, everything gets mature over 3 to 4 years of age. Generally, the ideal time for toilet training is between 3 to 4 years of age. How should we go about for toilet training? Always better to follow the rule of 1. What is this rule of 1? It has to be done by a single person. It has to be by one routine. That is, the routine is like we have to capitalize on the gastrocolic reflex 5 to 10 minutes after each major meal, and it should be at the same place. And you have to use a single word. Either you can say poo or potty, etc. for toilet training. So in practice, how do you do? We will ask the child to sit in the toilet 2 to 3 times after the major meals, usually within 30 minutes of meal intake. This is to, as already mentioned, this is to capitalize the gastrocolic reflex. And if the child, and to ensure painless defecation, and if anal fissures and things like are there, you have to treat that also. And what about the position? The ideal position is sitting in the squatting position in the Indian toilet. And if the child is using European toilet, the child has to be provided with a footrest as shown in the picture. What is the basis for that? The basis for that is that in the continent state, the pivorectalis muscle will be acting as a sling and it will be choking the rectum, resulting in a 95-degree angulation. If this angulation is there, the defecatory process will not be smooth. If we adopt a squatting position in the Indian toilet, this will be the pattern. Like this angle will be, the pivorectalis sling will be relaxed, the angulation will be obstructed, it will be obliterated, the rectum will become straight so that the passage will be very smooth. So this kind of an angulation can be attained by providing a footrest for a child who is using European toilet. And every time the child defecates, some positive reinforcement or reward has to be given. And a stool diary may be kept to note the bowel movements, the consistency of the stool, see whether fecal incontinence is there or not. If there is any pain or discomfort, then we have to note the laxative dose which the child is receiving. This is how we do the toilet training in practice. Fallacy number 4. What about treating a child who has functional constipation by using fibers alone? Increasing the fluid intake above normal to increasing the fluid intake above normal to treat childhood constipation. Fiber and increasing the fluid. What is the take on that? Increasing dietary fiber intake accompanied by extensive behavioral interventions does not increase bowel frequency or reduce the requirement of laxative. This has been proven by multiple studies. So simply dietary interventions alone are not going to work. Everything goes hand in hand. Education, early toilet training, diet, then comes the role of pharmacotherapy. So how much dietary fiber should a child require ideally? Simply as a thumb rule, we can compute the optimum amount of fiber that has to be consumed by using the formula. Dietary fiber consumption per day should be age in years plus 5 grams per day. how this can be provided in practice. We should tell the parents what serving size, how much serving size will provide how much amount of fiber. It's clearly shown in this picture. The fruits shown in this panel, that will be roughly 100 grams will be providing 2 to 3 grams of fiber, whereas on the right panel, the fruits are roughly 200 grams, that will be providing double the amount of fiber. If one such serving will provide 2 to 6 grams of fiber, then vegetables like radish, carrot, and cucumber, each 100 grams will be providing 4 to 6 grams. And green leafy vegetable, a serving size of 50 grams will be providing similar amount of fiber. Extra fluid intake in children with functional constipation showed insufficient evidence for its advantageous effect on constipation symptoms alone. So all these as a remedy by itself is not a solution for the problem. So everything should work in tandem. So what are the take-home messages on diet in the management of chronic constipation? Always promote breastfeeding, exclusive breastfeeding for about 6 months. Cereal supplementation only after 6 months of life, because that can result in conditions like celiac disease and all, because the early introduction of gluten and things like that. Ensure adequate intake of water. Cut down the milk and dairy products, soft drinks and carbonated beverages and bakery products. Avoid junk foods like chips, Maggi, burgers, pizza, etc. Dietary fiber has to be 18 years plus 5 grams, as mentioned earlier. And what is more important is that dietary changes need to be a permanent one, and the entire family should have a commitment rather than telling the child alone to absorb those dietary things. Fallacy number 5. What about giving probiotics to treat a child who has constipation? This thought has arisen from the finding that the microbiota in healthy individuals and those children who are having chronic constipation really are different actually. The microbiota profile are different between healthy children versus those children who are having chronic constipation. So from this observation came the thought that probiotics could be used as a management strategy for treating constipation. But as of now, there is insufficient evidence to support the use of probiotics in children with functional constipation. Fallacy number 6. Without addressing fecal impaction, resorting to maintenance therapy. Before we start treatment, we should assess whether there is any need for disinfection by a careful, meticulous examination. Why fecal impaction is disinfection is important? Because fecal impaction is seen in more than 2/3 of children with functional constipation. How can we identify fecal impaction? It can be identified by a hard fecal mass in the lower abdomen or presence of large hard stools on rectal examination. Why fecal disinfection is important? Because as a result of fecal disinfection, no residual hard fecal matter will be retained in the colon. Then after disinfection, the maintenance therapy can keep the bowel moving and empty regularly. It will facilitate proper anorectal reflexes and pelvic floor coordination, which has been mentioned earlier. So in short, disinfection will decompress the rectum. It will re-establish normal stooling pattern and it will prevent fecal soiling. How can we do fecal disinfection? It's otherwise called as clean out. It can be done by an oral route by giving rectal enema or manual evacuation. But the preferred one will be manual evacuation has to be resorted only if the above measures failed, and that has to be done under anesthesia only. The preferred route will be oral route. And after disinfection, we need to reassess the child after 1 week whether re-impaction has occurred or not. So only after attaining a successful disinfection, we should proceed with maintenance therapy. So how do we do disinfection in practice? The preferred agent is polyethylene glycol. You can use either 3350 or PET 4000. It can be done at home or at hospital. The dose is 1 to 1.5 gram per kg in 2 divided doses into 3 consecutive days. If we are admitting the child, it has to be given 25 ml per kg per hour orally or by nasogastric tube in young children. What is the endpoint of disinfection? This has to be very clearly told to the parents, otherwise they will think that the child is having diarrhea. The endpoint is that the rectal effluent should be pretty clear. How long can we give the medication? We can initially give for 3 days, and if really required, it can be extended for further 3 days, but never more than 5 to 6 days. During this procedure, during this disinfection procedure, younger children may require IV fluids to maintain hydration. At times, children may complain of loose stools, bloating, flatulence, nausea, and vomiting. What about disinfection or clean out in smaller children, like newborns and all? PEG you cannot use for children less than 12 months of age. In neonates and all, saline can be used. Depending on the body weight, you can titrate the dose. The other agent is phosphate soda. And for maintenance therapy, what are the drugs available at our disposal? You have the osmotic laxative, which are disaccharides like lactulose and lactitol, and milk of magnesia. The age-old remedies like milk of magnesia, liquid paraffin, which we rarely use in practice nowadays. And polyethylene glycol is the upfront medication nowadays. It has been a game changer laxative in practice with the very good results in comparison to the other medications. Maintenance therapy, what is the idea behind maintenance therapy? That ensures complete daily emptying of the lower bowel. It prevents fecal incontinence and abdominal pain, and it should be individualized and customized. The dose needs to be titrated. The endpoint is like the child should have at least 1 or 2 bowel movements daily. Osmotic laxatives are the mainstay of maintenance therapy in children. How does this act? They draw water from and the stool is made softer so that it is very easy to pass. Polyethylene glycol and lactulose and lactitol are the preferred agents. Polyethylene glycol is the first choice anyway. It is basically a non-toxic water-soluble polymer. It is very minimally absorbed in the GI tract. Around 99% of PEG is recovered in feces and the remainder is excreted in urine. It's a biologically inert substance. It doesn't cause any interaction. It is not metabolized by chronic bacteria, unlike lactulose. It doesn't influence the movement of other solute as it carries no charge. Now, the laxative effect is not only achieved by osmotic, apart from the osmotic effect, which has been mentioned earlier, it has a unique interaction with the water molecule. It actually results in, it alters the physical chemistry of the solution, which leads to sequestration of more water. That itself makes the stool softer so that the expulsion is easy. When administered by mouth, PEG increases the water content of the stool and the effect is dose dependent. And following oral ingestion of PEG, it takes 24 to 48 hours to see the effect in the form of passage of loose stools. What are the formulations available? We have a 3350 formulation, which is available as a powder, which needs dilution. And it is also available as in combination with electrolytes like sodium chloride, potassium chloride, sodium bicarbonate, and sodium sulfate. That is PEG 3350 with electrolyte. Then PEG 4000 is also available, which is available in a liquid formulation for which no dilution is really required. So PEG is the first line therapy and is more effective as compared to lactulose or lactitol. What is the maintenance dose? Maintenance dose is less compared to the disinfection dose. It is 0.5 to 1 gram per kg for children more than 12 months of age. The side effects will be like bloating, abdominal pain, cramps, vomiting, and loose stools. It's not that common. It is safe for both short as well as long-term use. Disaccharides, the classical example is lactulose. It is also a non-absorbable synthetic disaccharide. It consists of galactose and fructose. Once lactose is taken, it undergoes fermentation in the colon. It will result in the formation of metabolites like short-chain fatty acid, carbon dioxide, and hydrogen, which will improve the colonic motility. It will act as an osmotic laxative. It will soften the stool and result in fecal defecation. The dose is roughly 1 to 2 ml per kg as a BD dosage. The side effect is abdominal discomfort and distension due to the metabolites that are produced. Lactitol is the other disaccharide. It is an analog of lactulose. It consists of galactose and sorbitol. The advantage over lactulose is that it's more palatable. The dose is 250 to 400 milligram per kg. So, in what way does PEG scores over lactulose? There has been a head-to-head comparison in Indian children from a North Indian center where they have an experience of more than 310 cases. The findings of this study was, in a developing country like India, functional constipation is the most common cause of constipation in children. In their series, more than 85% it was functional constipation. Simple clinical parameters like delayed passage of meconium, presence of growth failure, absence of retentive posture, and absence of fecal impaction suggest an organic cause. Although PEG and lactose were equally both effective in the series, PEG had an edge over lactose as the need for switchover was uncommon. What is seen that over a period of time, these children will develop tolerance to this thing and lose efficacy. So switchover may be required in the lactose group in comparison to PEG group. To summarize, PEG is the first-line therapy for functional constipation in children. Under 12 months, the only drug recommended is lactose or lactitol. Or if the child is having no response or intolerance due to non-palatability of PEG, we can try lactose and lactitol. And two osmotic agents should not be given concurrently because they act by the same mechanism of action. So when do we require a stimulant laxative? The stimulant laxatives are required only as a rescue therapy. They should not be given for prolonged period. What is this rescue therapy? Those children who are already on maintenance therapy, if they develop acute or sudden episode of constipation while on regular compliant maintenance therapy, when they develop such symptoms, then there is a need for rescue therapy for 2 to 3 days to tide over the acute episode of constipation, and then it has to be tapered and stopped. It has to be stopped after 2 to 3 days. What are the stimulant laxatives that are available at our disposal? Bisacodyl is one drug. Bisacodyl should not be used in children less than 3 years of age. It stimulates colonic motility, promotes secretion, and inhibition of absorption of water and electrolytes. It has if used by the oral route, the effect is noted within 6 to 8 hours. It's given as a single bedtime dose. If it is given through the rectal route, the onset of action is seen as early as 30 to 60 minutes. The side effects are abdominal cramps, diarrhea, electrolyte imbalance like hypokalemia, and proctitis on prolonged use. And on short-term use, such side effects are very rarely seen, and it is contraindicated in children with proctitis or anal fissures. What is the other stimulant laxative that is used? Sodium picosulfate. It acts through its active metabolite that is produced by the bacteria and increases the peristalsis of gut. It's given as an OD dosage. In small children, 1 month to 4 years of age, 2.5 to 10 milligram would suffice, whereas in older children from 4 to 18 years, slightly higher dose ranging from 2.5 to 20 milligram per day will be sufficient. It's available as a liquid formulation, just like bisacodyl. It's contraindicated in proctitis and gaseous abdominal distension. What is the fallacy number 7? Treating a child who has constipation with laxative for duration of 2 weeks. What is the take on this fallacy? When should we decide on stopping the maintenance therapy and how early we can do? For stopping treatment, we need to have certain criteria satisfied. Long-term maintenance therapy is generally needed. The child needs to be symptom-free while on maintenance therapy for at least 6 months. And the tapering should not be early and rapid. The maintenance therapy should be gradually weaned off over 3 months rather than abruptly discontinued. This is very essential to prevent relapse. And before beginning the treatment itself, we should counsel the parents that the child needs treatment minimum for 6 to 9 months for optimum results. What is the follow-up? How should we structure the follow-up in practice? We have to reduce the dose of the laxative only after the stool pattern has become normal. A stool diary is helpful in this regard. No abrupt stoppage of medicine should be resorted. While giving maintenance therapy, I should ensure that fecal impaction should not recur. If that happens, rescue therapy has to be offered. And the diet modification needs to be a sustained one. And toilet training should be started after around 3 to 4 years, and it has to be continued for 2 to 3 years, the way that I mentioned earlier. And how should we plan the review? Initially, you should ask the child for a weekly review for the first 2 to 3 weeks. Then you can space it out monthly till stooling is normal, and finally bi-monthly for 6 months to a year. So when should we refer children? A child with functional constipation is not responding to optimal conventional treatment for at least 3 months, despite good compliance, or if there are red flag signs, these children needs referral. So what are the key messages? Functional constipation is the most common etiology for chronic constipation in children. And functional constipation is a positive diagnosis, and most of them require only good history and clinical examination. Investigations are rarely required for diagnosing functional constipation. There should not be a wait and watch approach in the management. There is no role for wait and watch approach in the management of functional constipation because of the adverse outcomes. And we need to educate the parents for toilet training. We should practically tell how it has to be done, the rule of one, etc., the toilet position, etc. Diet alone is not sufficient for a successful management outcome. Always we have to assess the need for disinfection, and the laxative needs to be continued. The preferred laxative is polyethylene glycol, and it has to be there for minimum 6 to 9 months before deciding on a tapered withdrawal. The red flags are there, or if the child is refractory to the optimal regimen for optimum period, then referral is warranted. So if you resort to all these measures, this ordeal can be transformed into a comfortable experience both for the child as well as the parent and the caregiver. Manoj?
Thank you, Dr. Prasanth, for a very simple and informative talk. Now the topic is open for discussion. Anybody having any doubts can clear from the speaker. എനിക്ക് തോന്നുന്നു ഈ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റാത്തതുകൊണ്ട് വല്ല പ്രശ്നമുണ്ടോ എന്നറിയാം.
എല്ലാവർക്കും ഇൻഡിവിജ്വലി അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുമല്ലോ, അല്ലെങ്കിൽ ചാറ്റ് ബോക്സിൽ കൊടുക്കുകയാണെങ്കിൽ ഡൗട്ട്സ് ചാറ്റ് ബോക്സിൽ കൊടുത്താലും മതി.
There is no question in the chat box.
പ്രശാന്ത് ഒരു ഇത്
Sir, let me know the available preparation. Hello. Hello.
Kumari madam ആണോ?
Let me know the available preparations of PEG 400 syrup.
Madam,
commercial preparation. Preparations available. Let me know the available preparation of PEG 400 syrup. Commercial preparation.
Madam, 3350 is available. 3350 with electrolyte is available, and now we have even 4000 also available.
Syrup. Is it syrup?
No, madam. Only PEG 4000 is available as a liquid formulation, and some of the electrolyte
can be given to children below 3 years.
Children below 3 years also you can use. More than 12 months, PEG is indicated. PEG is approved. There are now studies telling that even
below 1 year. Let me know the what are the preparations for below 1 year.
Below 1 year, even for 6 months to 6 months to even in children older than 6 months also you can use PEG. Otherwise, if that is not available, lactulose or lactitol is the option.
Okay, thank you.
Nowadays we don't use this liquid paraffin or this milk of magnesia.
Okay, thank you.
Chat box question ഉണ്ടല്ലോ.
Please clarify on constipation in infants smaller than 6 months. When we encounter children with constipation in children less than 6 months, always we have to be skeptical about the organic causes. And if the child is exclusively breastfed, there is no reason why the child should develop constipation. Then what we see usually in practice is like most of these mothers may be on some complementary or Ayurvedic medication as a remedy for postpartum care. In such children, in babies nursed by such mothers, we see constipation as a symptom. I don't know really whether there is any scientific basis for this association, but it's quite commonly seen in practice. Then in this context, we need to be aware of a condition called infant dyschezia. This is usually seen in children less than 6 months and all. But the children will be actually screaming during defecation. This is really not constipation actually. Then I think as an extension to that question, Dr. Ashwati has asked, like, is it feasible to wait till 6 days? This is a very yesterday also this actually asked. To answer this, basically we need to understand that for each child the frequency of defecation may be different. So if we just apply the frequency alone as a criteria, that may not be enough. But in this context, we need to keep in mind that if the child is having other symptoms like abdominal distension, vomiting, and all, then that is really an indication for disinfection. For that, we can for small babies, saline enema will be an option. Bisacodyl suppository, and the use of regarding the use of suppositories, I would like to say that we should desist from using rectal medication, because that in itself will be a painful stimuli for the child, and that will be a trigger for the stool withholding behavior. As far as possible, the suppositories should be avoided, which is very rampantly used. And as a rule, in less than 3 years of age, absolute no for parenteral medication, other than as a rescue option. There is one more question in the chat box that has been answered.
പ്രശാന്ത്, ഇപ്പൊ നമ്മൾ സാധാരണ കാഷ്വാലിറ്റിയിലെ സാധാരണ കാണുന്നത് ഇപ്പൊ ഒരു 4 ദിവസമായിട്ട്, ഇപ്പം ഇനി ഒരു 3 months 4 months ഒക്കെ ഉള്ള ഇൻഫൻസ് 4 ദിവസമായി അല്ലെ 5 ദിവസമായിട്ട് മോഷൻ പോകുന്നില്ല, ഭയങ്കര പെയിൻ ആണ്, അബ്ഡോമിനൽ ഡിസ്റ്റൻഷൻ എന്ന് പറഞ്ഞ് വരുമ്പോഴേ സാധാരണ നമ്മൾ കാഷ്വാലിറ്റിയിൽ അപ്പോഴേ ഒരു ഡൾക്കോലാക്സ് സപ്പോസിറ്ററി ആണല്ലോ റൊട്ടീൻ ഇത്. അപ്പൊ അങ്ങനെ വരുമ്പോഴത്തേക്കും നമ്മള് പിന്നെ ഡ്രഗ് ഓഫ് ചോയ്സ് എങ്ങനെയായിരിക്കും? ഒരു
സലൈൻ എനിമയാണ് കുറച്ചുകൂടെ റെക്കമെൻഡ് ആയിട്ടുള്ളത്. പിന്നെ ഈ പറഞ്ഞ പോലെ സപ്പോസ് ഡൾക്കോലാക്സ് ശരിക്കും പറഞ്ഞു കഴിഞ്ഞാൽ ബിസക്കോഡിൽ ഇങ്ങനെയുള്ള സപ്പോസിറ്ററീസ് ഒക്കെ ലെസ് ദാൻ 3 years ആക്ച്വലി റെക്കമെൻഡ് അല്ല. Using off label actually. So that will be, as already mentioned, they will be inflicting a painful stimulus to the child. Parenteral medications in the basic problem adana. It will not solve the further problem. It will not solve the root problem. പല കേസിലും പലപ്പോഴും കാണുന്നത് ഡിസിംപാക്ഷന്റെ നീഡ് അസസ് ചെയ്യാതെ ഡയറക്റ്റ് ആയിട്ട് മെയിൻ്റനൻസ് തെറാപ്പി കൊടുക്കും. അപ്പൊ നമുക്ക് ഒരിക്കലും അത് സക്സസ്ഫുൾ ആവത്തില്ല. അൺലെസ് വി അറ്റൈൻ എ സക്സസ്ഫുൾ ഡിസിംപാക്ഷൻ, we are not going to have a good outcome for the treatment of constipation. എന്നിട്ട് ഒരു ഗ്രൂപ്പ് ഓഫ് ഡ്രഗ് കൊടുക്കും, മേ ബി ഫോർ എക്സാമ്പിൾ ലാക്ടോസോ അല്ലെങ്കിൽ വേറെ എന്തെങ്കിലും ഡ്രഗ് കൊടുക്കും. ഒരു 10 days 14 days we'll wait, we'll see that there is no response, and we'll immediately switch over. The basic problem is that we have not attended to whether there was a need for disinfection, and if disinfection has been attained, we have not given for a sufficient period. This is the commonest reason for a relapse of symptom, premature withdrawal of medication. Treatment proper ആയിട്ട് കൊടുക്കുമ്പോൾ we will get response by as early as ഒരു 4 to 6 weeks ഒക്കെ ആകുമ്പോൾ നല്ല റെസ്പോൺസ് കിട്ടും. But it will be too premature to withdraw the medication then.
അപ്പൊ നമ്മൾ ഈ ഇതുപോലൊരു ഒരു 5 months ഒക്കെ ഉള്ള ആള് ഒരു കോൺസ്റ്റിപ്പേഷൻ ഫോർ 4-5 days അബ്ഡോമിനൽ ഡിസ്റ്റൻഷൻ, ഭയങ്കര ഇറിറ്റബിൾ ക്രൈ എന്ന് പറഞ്ഞ രാത്രി സാധാരണ കാഷ്വാലിറ്റിയിൽ വരുമ്പോ നമ്മള്
അതൊരു ട്രബിൾസം ആയിരിക്കും.
അപ്പൊ അവര് അത് ഉദ്ദേശിച്ചായിരിക്കും വരുന്നത്. സാധാരണ പറയുന്ന സപ്പോസിറ്ററി വെക്കണം അല്ലെങ്കിൽ എനിമ വെക്കണം എന്ന് പറഞ്ഞിട്ടായിരിക്കുമല്ലോ അവര് വരുന്നത്.
ചൈൽഡിന് ഡിസ്ട്രസിംഗ് ആണ് അസോസിയേറ്റഡ് സിംറ്റംസ് ഉണ്ടെങ്കിൽ യെസ്, അതർവൈസ് 2 ദിവസം 3 ദിവസം ഒക്കെ പോയില്ല എന്ന് പറഞ്ഞിട്ട് കുഴപ്പമൊന്നുമില്ല.
അതെ. അപ്പൊ അതിന് ഡൾക്കോലാക്സ് വെക്കാമോ? നമ്മൾ 5 months ഒക്കെ പറയുമ്പോൾ ലെസ് ദാൻ 3 years?
The approved one is actually the saline enema or glycerin enema.
ശരി. ഈ ഗ്ലിസറിൻ എനിമ വോളിയം വല്ലതും ഉണ്ടോ പ്രശാന്ത്?
നേരത്തെ അത് പറഞ്ഞിട്ടുണ്ടായിരുന്നു, ആ ഒരു ബോഡി വെയിറ്റ് അനുസരിച്ചിട്ട്.
ശരി.
ബോഡി വെയിറ്റും ഏജും അനുസരിച്ചിട്ടാണ്.
ശരി. there is no more doubts.
Sir, chronic constipation, anal fissure. Sir, കേൾക്കുന്നുണ്ടോ sir? Hello.
ഡോക്ടർ സന്ദീപ് അല്ലേ?
Sir, അതെ sir. Sir, പിന്നെ ഈ chronic constipation ഈ pediatric gate anal fissures ഒരു ചാൻസ് എങ്ങനെയാണ്? സാധാരണ നമ്മള്
ലോങ് സ്റ്റാൻഡിംഗ് ആയിട്ടുണ്ടെങ്കിൽ കാണാറുണ്ട്. സിമ്പിൾ ലിഗ്നോകൈൻ ജെല്ലി വിൽ ബി സഫിഷ്യന്റ്. സിമ്പിൾ ലിഗ്നോകൈൻ ജെല്ലി വിൽ ബി സഫിഷ്യന്റ്. ജസ്റ്റ് ആ പെയിൻഫുൾ സ്റ്റിമുലൈ ഒന്ന് അമിനറേറ്റ് ചെയ്യാൻ വേണ്ടിയിട്ട്, പെയിൻഫുൾ സ്റ്റിമുലൈ അമിനറേറ്റ് ചെയ്തിട്ട് വേണം നമ്മൾ ലാക്സേറ്റീവ് കൊടുക്കാൻ. അല്ലെങ്കിൽ ഈ പെയിൻ ഉള്ളത് കൊണ്ട് ചൈൽഡ് മേ ബി ഹോൾഡിംഗ് ഓൺ. പെയിൻ ഇസ് ദ ഫസ്റ്റ് ഇവന്റ്, ഇൻസൈറ്റിംഗ് ഇവന്റ്. പെയിൻ മേ ബി ഡ്യൂ ടു മൾട്ടിപ്പിൾ റീസൺ. അത് ടാക്കിൾ ചെയ്തിട്ട് പിന്നെ നമ്മൾ ഓരോരോ ഇതായിട്ട് വിത്ത്ഹോൾഡിംഗ് ബിഹേവിയർ കംപ്ലീറ്റ് ആയിട്ട് മാറ്റി ഡിസിൻഫെക്ഷനും മാറ്റിയാൽ മാത്രമേ നമുക്കൊരു നല്ല ഔട്ട്കം കിട്ടത്തുള്ളൂ എപ്പോഴും.
തിരുവനന്തപുരത്ത് നിന്ന് ഡോക്ടർ രാജേഷ് ആണ്. ഒരു സംശയം ചോദിക്കട്ടെ സാറേ, നമുക്ക് ഈ പെയിൻ കാരണം ബേബീസ് ഇങ്ങനെ ഹോൾഡ് ചെയ്യുന്നത് മാറ്റാനായിട്ട് നമുക്ക് സൈക്കോളജിക്കലായിട്ട് നിർദ്ദേശമായിട്ട് എന്തൊക്കെ ചെയ്യുന്നത് ഓർക്കും ചെയ്യാൻ പറ്റും? അവരൊരു ശീലമായിട്ട് ഇങ്ങനെ ഹോൾഡ് ചെയ്യുന്ന ശീലം ഭയങ്കര കൂടി വരുന്നുണ്ട് ഇപ്പോഴത്തെ ജനറേഷൻ പിള്ളേർക്ക്.
ഹോൾഡ് ചെയ്യുന്നത് പലപ്പോഴും ഈ പാരന്റ്സ് വിചാരിക്കും ഇവര് ഈ പറയുന്ന ഡിഫിക്കറ്റ് ചെയ്യാനായിട്ടുള്ള പോസ്റ്റർ ആണ് എന്ന് അവർ മിസ്കൺസ്ട്രൂ ചെയ്യും. അപ്പൊ അത് നമ്മൾ പറഞ്ഞ് മനസ്സിലാക്കി കൊടുക്കണം. ഇത് ആക്ച്വലി ഒരു സ്റ്റൂൾ വിത്ത് ഹോൾഡിംഗ് പോസ്റ്റർ ആണ്. അത് അവോയ്ഡ് ചെയ്യാൻ വേണ്ടിയിട്ടാണ് ഈ ടോയ്ലറ്റ് ട്രെയിനിങ് പറഞ്ഞേക്കുന്നത്. മേജർ മീൽസ് കഴിഞ്ഞാൽ ഒരു 5 to 10 minutes you make the child sit in the potty. If it is Indian toilet, that is okay. If you are using an European toilet, make sure that the child is provided with the footrest. That will only ensure the proper angulation. Otherwise what happens is that our anatomy favorable ആയിരിക്കത്തില്ല. ചൈൽഡ് ഇങ്ങനെ അവോയ്ഡ് ചെയ്യാൻ ശ്രമിച്ചുകൊണ്ടേയിരിക്കും. But the sphincters are not relaxing, the angles are not obliterated. That will not be a smooth experience. അപ്പൊ ഇങ്ങനെ ഒരു ഫുഡ് റെസ്റ്റ് ഒക്കെ കൊടുത്തു കഴിഞ്ഞാൽ നല്ല പ്രോപ്പർ ആയിട്ടുള്ള ഒരു പൊസിഷനിങ് വരികയും ആംഗിള് മാറുകയും ആ പ്രോപ്പർ റിഫ്ലക്സസ് ഒക്കെ പ്രോപ്പർ ആവുകയും പെൽവിക് ഫ്ലോസ് മസിൽസ് ഒക്കെ റിലാക്സ് ചെയ്യാനായിട്ടൊക്കെ ഫെസിലിറ്റേറ്റ് ചെയ്യാൻ വേണ്ടിയിട്ടാണ് ഇത്. അത് നമ്മൾ റുട്ടീൻ ആയിട്ട് ഒരു എല്ലാ മേജർ മീൽസ് വരും. ബിക്കോസ് ഒരു 4 years വരെ ഗാസ്ട്രോകോളിക് റിഫ്ലക്സ് കാണുമല്ലോ. വി ഹാവ് ടു ക്യാപിറ്റലൈസ് ഓൺ ദാറ്റ്. അപ്പൊ അങ്ങനെ അത് ചെയ്ത് കഴിഞ്ഞ് ഇവര് ബവൽസ് നോർമൽ ആയി കഴിഞ്ഞിട്ട് പിന്നെ ഒരു 2 to 3 years കൂടെ നമ്മൾ അങ്ങനെ അത് കണ്ടിന്യൂ ചെയ്ത് പോവുകയാണെങ്കിൽ പിന്നെ അത് ടേപ്പർ ചെയ്ത് പോകും. പിന്നീട് അവർക്ക് ഒരു സിംപ്റ്റം റിലാപ്സ് ഉണ്ടാവത്തില്ല. എല്ലാം വേണം. എഡ്യൂക്കേഷൻ ഈസ് ഇമ്പോർട്ടന്റ്, ടോയ്ലറ്റ് ട്രെയിനിങ് ഈസ് ഇമ്പോർട്ടന്റ്, ആൻഡ് ഡ്രഗ്സ്, ഡയറ്റ്. ദീസ് ആർ 4 pillars ആർ ഈക്വലി ഇമ്പോർട്ടന്റ്. ഓരോന്നും ഇൻഡിവിജ്വൽ ആയിട്ട് ഒരു വലിയൊരു എഫക്ട് ഒന്നും തരത്തില്ല. എവറിത്തിങ് ഷുഡ് ഗോ ഹാൻഡ് ഇൻ ഹാൻഡ്. പിന്നെ പ്രൊലോങ്ഡ് ട്രീറ്റ്മെന്റിന്റെ കാര്യം യു ഷുഡ് ടെൽ ഇൻ ദ ഫസ്റ്റ് വിസിറ്റ് ഇറ്റ്സെൽഫ്.
Okay. Thank you, sir.
I think there is a question about fistula and ano. Fistula and ano, അത് ഒരു സർജിക്കൽ ഡൊമൈനിലാണ്, സർജന്റെ ഫീൽഡാണ്. പക്ഷെ ഇപ്പൊ ഫിസ്റ്റുല ആൻഡ് നാനോ ചോദിച്ചുകൊണ്ട് ഞാനൊരു കാര്യം പറയാം. ഒരു ഇതുമായിട്ട് റിലേറ്റഡ് അല്ല. പലപ്പോഴും നമ്മുടെ അടുത്ത് വരുന്ന പല ഫിസ്റ്റുല ആൻഡ് നാനോയും മേ ബി ഒരു ക്രോണിക് ആയിട്ടുള്ള ഫിസ്റ്റുല ആൻഡ് നാനോ ആയിരിക്കും. അപ്പൊ അങ്ങനെ വരുന്ന കേസിൽ യു ഹാവ് ടു റിയലി റൂൾ ഔട്ട് IBD. Because that may be a presentation of inflammatory bowel disease. പലപ്പോഴും നമ്മൾ 1-2 വർഷം കഴിഞ്ഞിട്ട് നോൺ ഹീലിംഗ് ഫിസ്റ്റുല എന്ന് പറഞ്ഞു വരും. That is the situation where you have to suspect inflammatory bowel disease. Because അപ്പൊ തന്നെ നാച്ചുറൽ ഹിസ്റ്ററി തന്നെ ഒത്തിരി നാളായിട്ടുണ്ടാവും. മേ ബി ഒരു 1 or 2 years കഴിയുമ്പോഴത്തേക്ക് സിവിയർ പെരിയനൽ ഫിസ്റ്റുലൈസിംഗ് ഡിസീസ് ഒക്കെ ആയിട്ട് പലപ്പോഴും കാണാറുണ്ട്. മെഡിക്കലി ഒരു വലിയ റോളൊന്നുമില്ല. സർജൻസ് ഡൊമൈൻ ആണ്.
Any doubts on the illengal namak? I think we can wind up the session. Once again, thank you, Dr. Prasanth, on behalf of IAP Kollam and on behalf of Kgmoa. Thank you for accepting our invitation and delivering us a very informative talk. Over to Dr. Sandeep for vote of thanks.
Sir, first of all, we are very much thankful to Dr. Prasanth for this excellent presentation. നമ്മുടെ ഡേ ടു ഡേ ആക്ടിവിറ്റി, നമ്മുടെ ഡെയിലി OP-യിൽ നമ്മൾ കോമൺ ആയിട്ട് കാണുന്ന കുറെ സിനാരിയോ സാർ ഇവിടെ എക്സ്പ്ലെയിൻ ചെയ്തിട്ടുണ്ടായിരുന്നു. അത് വളരെ എനിക്ക് തോന്നുന്ന കുറെ ഡൗട്ട്സ് നമ്മൾ ഇതിന്റെ ഇടയ്ക്ക് വന്നില്ല. ഈവൻ ദോ പാർട്ടിസിപ്പൻസ് 50-ക്ക് മുകളിൽ ഉണ്ടായിരുന്നു. അപ്പം അതിൽ കുറെ പേര് സംശയങ്ങളൊക്കെ ചോദിച്ചു. സാറിന് വളരെയധികം നന്ദിയുണ്ട് ഒരു എക്സ്പ്ലെയിൻ പ്രസന്റേഷൻ തന്നതിൽ. അതുപോലെ താങ്ക്സ് ടു Kgmoa പ്രസിഡന്റ് ഡോക്ടർ റീന മാഡം, അതുപോലെ IAP പ്രസിഡന്റ് ഡോക്ടർ മനോജ് മണി. പിന്നെ വീണ്ടും നമുക്ക് ഇതുപോലെ ഒരു സെഷൻ കണ്ടക്ട് ചെയ്യാൻ പറ്റും എന്നുള്ളത് പൂർണ്ണ വിശ്വാസത്തോടെ എല്ലാവർക്കും നന്ദി. താങ്ക് യു.
Thank you all. Thank you all.
Thank you.
Thank
Good
you.
night.
Good night.